This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. Today, I'd like to provide you with an overview of pulmonary nodules.
Let me start my discussion of solitary pulmonary nodules with a case. This 55-year-old patient was so interesting that one of my residents, Dr. Jin, and I decided to publish this as a springboard to the topic at hand. The patient is a non-smoker who was found to have an incidental left lower lobe nodule found on lung sections of an abdominal CT done for another indication. The nodule over here is unusual in that it's not totally solid. It's actually classified as subsolid. It's not as dense as other soft tissues like the heart and muscles. In fact, it's so incomplete dense that on a soft tissue window it's invisible. If this had been a solid nodule, it would have shown up right in here, but we can't see it. Because of its characteristics, which I'll be going over in a little bit, we were so worried this might represent a cancer that we had this resected. Now, on resection, the pathology showed a well-differentiated papillary adenocarcinoma in a low power field. And on high power field, this showed the typical acinar pattern of glandular distribution. It's forming acinar units. They look like mucus-type glands. And most importantly, this spread through the lungs, through the soft tissue of the interstitium of the lung in what's called a lipidic, L-E-P-I-D-I-C pattern, lipidic pattern. In this pathology slide, a special immunofluorescent stain for thyroid transcription factor, also known as TTF1, was applied. As you can see, there's strong uptake of the stain, which is seen here in the dark brown, right in here. That's characteristic of a primary adenocarcinoma of the lung. Now, this patient wound up having an unusual form of alveolar carcinoma or adenocarcinoma called bronchoalveolar carcinoma, which you'll see has been reclassified, but the entire pattern of a ground glass nodule of that nature was suspicious from the beginning for this type of cancer, prompting the resection. So let's just talk about how we actually look at these nodules or masses. So our definitions. First of all, a pulmonary nodule is defined as any pulmonary nodule that's less than 30 millimeters, which is well demarcated and surrounded by lung parenchyma. This X-ray is almost normal. Heart's in the middle, lung fields are clear, but if you look really closely, there's an extra density right above my pointer that is a small pulmonary nodule. And if you saw this close up, you'd see it clearly stands out. If you look at the opposite side, there's nothing there. That's less than 3 centimeters, so that would be a pulmonary nodule. A pulmonary mass is similar definition, well demarcated, surrounded by lung parenchyma, but over 30 millimeters. The malignancy risk of nodules is related to the size of the nodule, obviously the larger, the higher risk, and its characteristics. Another factor we take is a pretest likelihood. For example, a 5 millimeter nodule in a non-smoker is much less likely to be cancer than the same size nodule in a heavy smoker. And that's because the incidence of lung cancer is already higher in smokers than non-smokers, so any nodule we stumble upon is suspicious. So we need to be able to describe these nodules to help us know what to do about them. So we look at the size, and officially we'll measure on the long and short axis and take the average. That's the size. So obviously a 4 by 6 nodule, if it's not perfectly round, would be described as a 5 millimeter nodule. We say if it's solid, which I haven't shown you yet, or subsolid, meaning it's not entirely solid. It has some hypodense areas. We'll say whether the edge is smooth, irregular, which is shaggy, or spiculated, which means it has some protrusions coming out. We'll talk about the location of the nodule. That can influence us. Whether they're solitary nodules or more than one, which are either 2 or multiple, and whether the nodule is calcified. Now, we see some benign patterns which we are very certain is calcified. For example, a fully calcified nodule, or one that I'll be showing you a little bit later that shows popcorn calcification, is always considered benign. But calcification itself is not proof of benignity. For example, a solid nodule with a little bit of calcification on the edge, just on the very edge, which we call eccentric calcification, could be malignant. For example, there may have been an old scar that was calcified, and later in life, growing out of the scar, away from the calcification area, could be a cancer. So there are occasions when a calcified nodule could be benign, but most calcified nodules are benign because they're fully calcified or they have very specific patterns such as popcorn calcification. If multiple nodules, we'll try to comment whether the sizes are similar, all homogeneous, maybe all 3 to 4 millimeters, or multiple sizes, for example, ranging from 2 millimeters to 12 millimeters. Although this fact doesn't prove whether something is benign or malignant, homogeneously sized multiple nodules are much more likely to be benign, where nodules that have multiple sizes are more likely to be malignant. That's because malignant metastases tend to have different ages. The ones that came earlier are larger, the ones that came later are smaller. So this is actually from our journal paper I mentioned, just showing classification of pulmonary nodules. A pulmonary nodule is either a solid nodule, which is homogeneous and dense, or subsolid, meaning there are some areas of hypoattenuation. Now, we break subsolids into two groups: pure ground glass, which is like the one I showed you, or part solid, where some areas are subsolid and other areas are fully solid. And I'll show you examples of these. What's important to know is any of these nodules can be malignant, a solid nodule or either of the subsolid nodules, pure ground glass or part solid. But on average, part solid nodules are very concerning for malignancy. Pure ground glass nodules are also concerning depending on their size and characteristics. And a solid nodule, especially if it's small, is usually low malignancy risk. It depends on the size, but a 3 millimeter solid nodule in a non-smoker has almost no malignancy risk, and a small solid nodule in a smoker does have a malignancy risk, but it tends to be on the low side, unless you know it's enlarging in size over time. So let's talk about types of pulmonary nodules. Of course, if it's a nodule, it must be under 30 millimeters. Solid nodules tend to be dense, homogeneous, and have Hounsfield units between 20 and 80. Now, what a Hounsfield unit is the density of radio opacity seen on a CT scan. So soft tissue density is 20 to 80. As things get denser, such as calcium density, the score goes way over 80. It can go up to 500 or 1,000. Under 20, for example, 0 to 20 is water density, and then as you get less dense, it goes to fat density, and finally, the least dense is air. Air might have a value of minus 500. So there's a scale from air, which is minus 500, all the way through soft tissue solid density, which is 20 to 80, and all the way up to extremely dense like calcium of 500. And that scale of rating density radiographically is called the Hounsfield scale. So here's a benign appearing nodule. It's a nodule because it's well circumscribed, it's under 30 millimeters, it's dense, and it's homogeneous. If you put the measuring stick on it in the computer from the CT scan, this might have a Hounsfield measurement average density of 40, right in the middle of soft tissue density. So we would say this is a benign appearing soft tissue nodule. Now, that's not to say this is benign. Any of these have a cancer risk, but how we followed these dependent on whether they've been growing and the type of patient we see this in. We'll take this a lot more seriously in a smoker than a non-smoker. We have some algorithms we use to tell us what to do about these when we find these as incidental findings. And I should mention, a finding like this is almost always incidental. There's no chance the patient would have any symptoms from something this small. Now here's an even smaller, some people we call this a ditzel or a schmutz. It's just a tiny little thing. These are so common, they're seen frequently on imaging studies. They're called indeterminate. They're really not that well demarcated. They're sort of solid. You see the edges, but they would count as a very nondescript, tiny, let's say 3 or 4 millimeter nodular density. And what to do about these will be a topic later on. Now, this is another nodule. It's actually not too different in size than the first benign appearing one, but it has little protrusions going into the lung. They're called spiculations. Any nodule that's spiculated we consider suspicious for cancer. Again, it doesn't have to be cancer. We see scars that are benign that look just like this. We would be much more concerned if we saw a suspicious nodule like this in a smoker, especially if we knew that this hadn't been present 1 or 2 years ago. So a new nodule that looks like this in a smoker is very suspicious for cancer. Now we're going to talk about some of these subsolid nodules. They're also less than 30 millimeters because they're a nodule. They're less dense than a solid nodule, so their Hounsfield units might be under 20. They could be inhomogeneous. There are brighter areas of white, less dense areas, entire areas that are just lung density. This is the exact one I had shown you in my case report. This is another one I'm going to show you its natural history because it's a very interesting progression that we figured out. So these are both examples of ground glass subsolid densities. These happen to be ground glass. There's no partial solid areas, but I'll show you one that's partial solid. It's the same idea. It's a ground glass, but there are areas of density right over here.
If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.